So as I mentioned, I'm Shelley Fuld Nasso. I'm CEO of the National Coalition for Cancer Survivorship. So for those of you who are just joining us now, I just wanted to give a couple of quick reminders. You can find the agenda and the bios for the speakers on the handouts tab. And please use the questions and chat function to ask questions of the presenters, and we'll get to questions after we go through some introductory comments from each of our panelists. And you can follow the conversation on Twitter using the hashtag CPR20. So I'm pleased to introduce the panelists for our next discussion on end of life for cancer patients. Blake Farmer of National Public Radio reported earlier this year on the challenges families face at the end of life because the hospice benefit does not always provide enough support. He quoted a caregiver who said, "I think that people aren't prepared for all the effort it takes to give someone a good death at home." We are pleased that Blake is able to join us today in the midst of his reporting about the impact of COVID-19 and the aftermath of the devastating tornadoes in Nashville. We also have Andrew MacPherson, Senior Advisor to the National Partnership for Hospice Innovation, to discuss policy implications of the Medicare hospice benefit. But first, we want to begin with the experiences of three caregivers: Lisa Rice, who is an NCCS board member, Donna Gentry, and Kimberly Acquaviva. Kim is also a professor at the School of Nursing at the University of Virginia and an expert in LGBTQ inclusive healthcare. So now I'm going to turn it over to Lisa to kick us off.
Okay, thanks, Shelley. And you said I have 5 minutes?
Yes.
I'm setting my timer. I'm trying. That's bad when you can't even find the timer. There we go. All right. Hi, everyone. I'm so glad everyone's here. My name's Lisa Rice, and as Shelley mentioned, I'm a member of the NCCS Board of Directors and a family caregiver. Since 1993, I've been closely involved with end-of-life care for 4 loved ones. Not all of those were cancer related, but all have been influential in my growth as a caregiver. My experiences have included, back in 1993, signing a do not resuscitate order for my sister, who then died in the hospital less than 12 hours later. Second, back in 2011, managing 24-hour at-home care for my father after he was released from a rehabilitation facility with multiple issues, and he was released for at-home hospice care, which I managed. 2014, I was supporting my best friend who died of a recurrence of metastatic inflammatory breast cancer. And I helped her as a patient advocate before and during hospice care. Some of her hospice care was inpatient, most of it was at home. And so I was a part of that with her mother and sister. And this is the experience I'll refer to most during the discussion today. But finally, in 2019, I was a primary caregiver for my mother, who died of advanced Alzheimer's and was a 2-time breast cancer survivor. While her cause of death wasn't cancer, many of the things that I learned, such as the importance of working with a good doctor on completion of a MOLST form, are applicable for care at the end of life, whether or not the actual cause of death is cancer. The chief lesson I've learned from all those experiences in helping these loved ones at the end of life is early conversations about what someone wants and needs at the end of their life. It's very important. Having that knowledge of what they want their end to be is so important, so that you can make good decisions with them, or in some cases on behalf of them. I learned to set aside shyness, and I know no one who knows me now could think that I'd be shy, but I learned to set aside shyness to advocate fully for a loved one by asking questions of medical staff, challenging them when they'd made assumptions that weren't correct, and making sure the medical staff knows the facts of the loved one's life and the disease progression. As an example, when my father had to go into the rehabilitation facility, his hospital notes were that he was aggressive and uncooperative and delusional. And I said to the nurse at the rehabilitation facility, look, he was pumped so full of drugs, and it was the first time he'd ever had any of these kinds of opioids. you've got to give him a chance to get back to normal. When I told him that just 10 days before he had been grocery shopping and caring for my mother, they were aghast. So you have to tell them what someone's lifestyle is like. And I think it's really important to know your loved one's priorities. Ask the questions early. It can be uncomfortable, but the conversations are so necessary. And what I've learned that it's not one conversation when someone falls ill, but the conversations over a lifetime that inform your ability to best help a loved one at the end of their life. Know what they want, know where they want to be, and know how you can best help. And I still have 52 seconds, so I'm going to say that I am not at my end of life, nor is my husband, but we have both signed advance directives, and we talk about what we want our end of life to be like. And with COVID-19 and the fact that I am a cancer survivor and that he is almost at, we don't know if is it over 60 or over 65, but he's in the middle of there. You know, we are supposedly considered high risk for this. So now we're talking about what's it going to be like, and what's going to happen if we can't get care in a hospital, if we have to care for each other at home at the end of our life within the next 4 to 6 weeks, which is just crazy, but you got to talk about it. So that's it. That's my 5 minutes.
Thank you, Lisa. You did a great job staying in your 5 minutes. I know you have more to say, and we're going to have time for more discussion later. So next, Donna.
I can't hear Donna.
Hold on. I think we're trying to get Donna's audio. Hold on one sec. Donna, we can't hear you. We're trying to unmute you. Donna, I think you have to unmute yourself. Can you check, because you're muted right now? Okay, while we get Donna's audio up, Kim, would you like to go ahead, and then we'll come back to Donna.
Absolutely. Can you hear me all right?
Yes, thank you.
So I apologize in advance if there's any barking. My son is doing a live Zoom college class simultaneous to me doing this, and we have 3 dogs. So hopefully they'll be quiet.
No problem.
So I'm speaking to you as a caregiver. Most recently, I was a caregiver to my wife, Kathy. She was diagnosed with ovarian cancer at the end of January 2019 and died 6 months later under the care of our family at home. And when I was in my 20s, I was the healthcare power of attorney and caregiver for the last 6 weeks of my mom's life. She died of ovarian cancer at age 52. So I've had both of those experiences. My mom had hospice for the last several days of her life. My wife did not. We both, Kathy and I, have been really actively involved in the field of hospice and palliative care, and huge fans of hospice and palliative care. But because we were a lesbian couple, we didn't feel comfortable inviting in any hospice program into our home unless they had an inclusive non-discrimination statement and training in place for their staff. And that was a tough decision, but a decision that I'm happy we made. She received outpatient palliative care through the University of Virginia, and we were able to meet her care needs at home. Definitely challenging. I think people don't understand how much work is involved in caring for a loved one at home when they're dying, but I wouldn't change anything about it. The only thing I would change is I wish that there were more inclusive hospices in place for people like Kathy and I all around the country, and I think that shift is certainly happening. But when it came to her own care, we were very fortunate in that we were able to meet those needs at home. I think one of the limitations when I think about the hospice Medicare benefit, and it's not something that Kathy and I had really thought about until we were in the situation, was some of the requirements of how frequent people need to make visits. And so Kathy and I are both introverts, and we have 3 very obnoxious dogs. And the idea of having to have a nurse visit every 2 weeks, or having to have people come in if we didn't need anything, it was something we chafed against, the idea of letting people into that cocoon of our home if we didn't need services. And so for the first time ever in my career, and Kathy certainly shared that it was the first time she'd really thought about it, was how many people are turned off by some of those limitations. So we cobbled together palliative care to give us as many of the benefits as we could that we would have had with hospice. We were not able to get medication delivery. That would have made life easier. We didn't need a nurse to come visit, but we had a palliative care nurse practitioner and a physician that we could call or email and get information from. So for us, it made me realize that if we had had a hospice, it would have meant intrusive visits that we didn't need, and that would have made her feel sicker. It would have medicalized something that really wasn't a medical crisis for us. And so that's just my own family's experience. Because I had worked in hospice for a long time, and so had Kathy, we were prepared for that day-to-day care at home. Not everybody is prepared for that. And I'm not saying that people shouldn't have access to the amazing services that hospice has, but I would love to see new models of hospice and financing and ways of delivery that are more like a buffet as opposed to a fixed plate dinner. So what you need when you need it. And for us, we would have, Kathy was eligible for hospice from the day she was diagnosed, and we knew it. And we made a decision not to do hospice. Had she been on hospice those 6 months, she would not have used many services, but it would have been intrusive for us. So I have all the love in the world for hospice and for palliative care. I'd love to see more creativity. The other piece around thinking about end of life for managing and being creative about it is my wife was managing symptoms with cannabis, and a number of hospices and medical directors I've spoken to are pretty clear that their staff can't be involved if there are drugs in the home. That's an issue. It's an issue of concern, and they can't provide advice or guidance on strains or delivery mechanisms for symptom relief. So for Kathy, we had a house full of weed and no need for nurse visits, and so for those reasons, it really wouldn't have been good. And so I think as we think about care at the end of life for hospice for cancer patients, we need to start thinking outside the box. And not being so regulatory focused, and really be focused more on the needs of the patient and family. Hopefully I didn't go over my 5 minutes.
I wasn't timing you, but that was great. Thank you so much, Kim. And Donna, you are not muted now, so you can go ahead. Thank you.
Hi, good morning. Yes, it's a pleasure to be here. So I'm a cancer survivor. I was diagnosed a 1.5 years ago with mantle cell lymphoma, and at the time of my diagnosis, I was the sole caregiver of my husband, who was just dying from Lewy body dementia. He was quite paralyzed and cognitively extremely limited. So it was the double stressor, and I know I'm not alone in having been in this case scenario, and my heart goes out to anyone who has experienced this. But I was given tremendous support through hospice. I will say there was good and bad. The good about them was that it was someone I could talk to about my confusion about whether I should be focusing on my husband or focusing on my own health. They were able to sort that out for me. And they were just a wonderful group to talk with. My family was also supportive. And we always had this communication of living better, not longer, living a more full life rather than a longer life. And I think these are the conversations that Lisa was speaking about earlier that are just so important. And as Kimberly was saying, think about how you want to have the surroundings in your house on those, end days. The most difficult thing for us, and that we were not prepared for, were we had some, as I became more compromised from the chemotherapy, I needed to get help in. And so the caregivers that came in were loving caregivers. These were private. This was not through hospice. The biggest problem came toward the end of life, and I believe and hope we'll have a little conversation about this today, about the tricky issues as a body is shutting down, as my husband's body was shutting down, the tricky issue of feeding and pushing fluids. And my feeling and the hospice feeling was, you kind of let the body shut down. The caregivers, the private caregivers, their feeling was, have another spoon of ice cream, another spoon of ice cream. And every time you put the spoon of ice cream into his mouth, of course, he ate it, but his eyes were closed. And he was, for all intents and purposes, on his way out. But this kind of almost spoon feeding, almost artificial nutrition, even though his advance directive was no artificial nutrition, it was happening via a spoon and good ice creams that they would bring in. And we would have conversations. And it's just something, I will say, one of the legal ways to handle this, because this becomes delicate. You don't want to say, don't feed my husband, but it becomes delicate. So by having the legal documents in place, I can't tell you how many times I would just drag it out and say, help me understand this. It looks to me as if there's supposed to be no artificial nutrition. And there were additional documents to the typical advance directive. There were two in particular that one is the MOLST that Lisa was referring to. In Maryland, it's called MOLST. I think around the country, it's called POLST, P-O-L-S-T, that very clearly delineates exactly what you mean by no artificial nutrition. And it'll actually say, do not, not even spoon fed. And there's yet another advance directive that I have subsequently received that I filled out for my own self, for my family, to help with me at my end term, where it says, if I'm not cognitively aware, if I'm not able to bring the spoon myself to my mouth, please do not feed me. And that's because I think it's the end, So anyhow, with that said, I'm so grateful for this opportunity. I'm so grateful for advocacy to help with the quality of life prior to death.
Thank you so much, Donna. I really appreciate that. Blake, let's turn it over to you to talk a little bit more about your reporting.
Sorry to make sure I was unmuted. Thanks for having me. I'm glad I could do this because if I recall, I wasn't going to be able to come to DC because of the timing, and now here we are, all remote. So, locally, I did a series of stories. There's been a couple that have aired nationally, but we sort of put them under this umbrella called Cost of Dying. So I work here in Nashville, but a lot of my reporting goes out through Kaiser Health News and NPR and on public radio programs around the country. And so, really, I started looking at hospice, because it's become this profitable industry in the last decade or so. A lot of healthcare companies based here in Nashville, nursing home companies that have gotten in on it, creating their own agencies. But I really got into this kind of thinking, why aren't more people getting into hospice earlier? I mean, I had just read Atul Gawande's book, Being Mortal. I was very inspired, frankly, by my own mother who had ALS. She died in November after more than a year on hospice, which actually has become another story that'll air nationally here soon. But as I started doing interviews, I realized that there was this less discussed storyline that seemed to be occurring, that people were kind of uncomfortable talking about, and it's really about the burden on caregivers. And one of the interviews that made it into my first story was with Dr. Jessica Zitter. You all may know of her. She's an intensive care physician in Oakland. She's sort of become this end-of-life evangelist after, watching folks in her hospitals die on ventilators. She wrote this book about all these extreme measures taken at the end of life that don't really consider quality of life. So she started working on this other project, and it was a documentary about a couple of friends of hers, Rick and Bambi. And it was supposed to be this beautiful love story about a husband taking his wife home, caring for her on hospice. She had called off treatment for cancer. So Dr. Zitter goes and she visits every week or so, and what she sees really surprises her is that Rick's health was starting to fail after getting up every night in the middle of the night to help his wife to the restroom to deal with pain or other needs, and he was really just sort of at the end of his rope. So Dr. Zitter sits her down and sits him down rather, and says, it's okay to ask for more help from hospice. And he's like, I have. They offered a volunteer a few hours a week, but he obviously needed something much more. She died after 2 months on hospice, but the average length of time, as many of you all know, is now much longer than that. Yeah, we have people who are still just a few days, and people consider that, largely not the point. But the numbers have grown so much because you now have people with diagnoses like COPD, ALS, and dementia primarily. So, they spend all this extra time on hospice, and even since hospice was designed for cancer patients, this focus on pain management is not something that is really all that helpful for them. So we ended up interviewing several families caring for loved ones with someone who had dementia, and they needed somebody to come be with their loved ones so they could take a break, a real break. And that's just not something most hospice agencies seem to provide or even feel compelled that they need to. Though if you look at the Medicare rules, it sort of seems like they are supposed to do that. So anyway, many of these folks are having to pay out of pocket for private caregivers, as I'm sure many of you all have seen. And frankly, they don't seem to mind because what they get from hospice, they really like. But then you talk to them about how hospice gets paid for, which they don't really understand. One man who I was talking to is taking care of his wife for a year on hospice. She had dementia. He sort of puts it all together. He realizes, does the math. His hospice agency had been paid $60,000 over the last year, and he was raiding their retirement funds to pay for a private caregiver for 5 or 6 hours a day. So anyway, there's lots of new dynamics in hospice because investors are so excited about it, and for-profit agencies tend to have fewer cancer patients, which aren't quite as profitable, more of these patients who spend a long time in there. So I even have more reporting to do on that front, but that's sort of just a taste of what I've gotten into, and I thank you for having me here.
Thank you. We're so glad you could join us. So next we'll go to Andrew, and I think Andrew's going to talk to us about some of the policy implications, including some of what Blake said about how some things that are paid for, like how do we apply the Medicare hospice benefits. So Andrew.
Sure. Thanks so much for having me today. I'm just honored to be with you. Thank you, Shelley. Ellen Stovall was a friend and a friend to the organizations that I represent, like the Coalition to Transform Advanced Care and also National Partnership for Hospice Innovation. Our CEO, Tom Kasumpis, was on your board and chair of your board actually for a long time. So I feel like we're amongst family here, and I'm just honored to be here to talk about the hospice benefit and some of the policy implications and some of the changes that we're seeing in Congress, and not just this administration, but previous administrations, and sort of take a look at where we've been, take a look at where we are, and just offer some sort of shameless predictions for where I think we might be going in the future. And I'll say at the outset that there's no question, to Blake's point, I think each panelist made this point, the hospice has become an industry. When hospice began, it was all not-for-profit programs. Today, about 70% of hospice programs are for-profit, and we've seen a lot of investment. So Blake is absolutely right that the hospice industry is changing rapidly. I represent, I'm the senior policy advisor to the National Partnership for Hospice Innovation, which has been around for, an organization that's been around for about 6 years now. We were founded in 2014, and we represent about 75 of the largest, most innovative not-for-profit hospice programs in the country. Frankly, we came together as an organization because there was a recognition that hospice was becoming more of an industry, and that the not-for-profit programs, community-based programs, needed representation in Washington, and that they have a unique sort of policy agenda. So that's who I'm here to represent today. I actually also was looking at NCCS's vision, and our visions of the two organizations just align so well that our vision is really that during the last stages of life, every American can experience exceptional quality care that matches their goals, values, and preferences. I think we've heard a little bit on the panel today about the notion of matching preferences with the care that people receive, and that really is our number one focus. I also want to say just at the outset that the current COVID-19 pandemic and this national crisis does present very unique challenges to hospice programs across the country, for-profit or not-for-profit. I'll talk about that more in just a moment. So, we all know the statistics, right? About 10% of the Medicare population accounts for over 57% of the costs. Studies show that about 42% of individuals have had some sort of discussion about end-of-life preferences, but only about just over 20% have actually put those wishes into writing. And you've heard the term MOLST and POLST. I actually serve on the National POLST Board of Directors, and this is a major issue that Americans are very interested in thinking about and talking about and wrestling with what it is that they want for their care, but we're not doing a very good job of supporting them in expressing those wishes and putting those wishes actually into a document that a physician could follow. About 90% of studies show that about 90% of physicians actually haven't even asked about end-of-life preferences. So we have a long way to go in this country, and I think this is a focus of NCCS that 70% of Americans, about 70%, want to die in the home setting, and yet about 70% do not. So there's big gaps that we need to close, and that's what our organization is focused on. So I want to just very briefly talk about sort of where we've been, where we are today, where I see us sort of going in the future. A decade ago, in terms of the politics of this issue and the policy issues surrounding hospice and palliative care and advanced illness care, were just unbelievably challenging. And during the debate around the ACA, spending time on Capitol Hill and with the Obama administration, it felt like you couldn't even sort of whisper end-of-life care without being accused of supporting rationing and other sorts of sort of deleterious policy choices. Well, we've come a long way since then. The COVID-19 pandemic is certainly bringing back some of those issues, but since the ACA was passed, we've seen just extraordinary progress in supporting those who are facing advanced illness and needing hospice care. We now place a value, I think, as probably everybody knows, on advanced care planning. So Medicare pays for advanced care planning. Medicare Advantage, which is about just under 40% of Medicare beneficiaries, are in a private health plan called Medicare Advantage. The Congress, through the Chronic Care Act, made major changes and allowed for extraordinary amount of flexibility in the Medicare Advantage program to allow for payment for palliative care as part of supplemental benefits in Medicare Advantage. CMMI, the Centers for Medicare and Medicaid Innovation, and CMS are testing how to have Medicare Advantage now pay for hospice. So it's known as the Hospice Carve-In. And also a lot of the quality measurement programs that we've seen at a CMS include measures related to advanced care planning and other really important measures that focus on people's end-of-life wishes. So I do think that we've made a lot of progress, even just today, this morning or last night, the CARES Act, which is this over $2 trillion now stimulus package that the Congress has passed, the Senate has passed so far on a bipartisan basis, includes really important hospice elements. Our organization has been advocating, for example, for the use of telehealth to meet the face-to-face visit requirement for hospice recertification. So if somebody who's on hospice and is terminally ill, lives longer than 180 days, if this legislation passes, physicians and other allied health professionals can have a face-to-face visit with that patient through telehealth. So even today, we're seeing kind of major changes to the hospice benefit. Also, there's been major cuts to hospice payment over the past decade or so, something known as sequestration, which was a 2% across the board cut to all providers in Medicare. This legislation that we're looking at today is going to lift that 2% cut for hospice programs. So even today, we're seeing sort of changes to the benefit. We're seeing a lot of innovation with respect to the benefit. And the question is, where do we go from here, right? And I'm very optimistic, frankly, that individuals are going. I think the hospice benefit, frankly, has a lot of changes that need to be made to it. It was written in the early 80s, became a permanent part of the Medicare program in 1983. We've just come so far since then, decades later, in thinking about people die differently today. People are living longer, and there's a lot of changes that we should be contemplating to the benefit to improve it. So our focus going forward at NPHI is really to continue to educate about just raise the visibility, quite frankly, of these issues related to advanced illness and end-of-life care, to have an honest, sort of thoughtful dialogue in Washington about what it means to have a high-quality end-of-life care experience, and to ensure that policy reflects that. So I'll stop there. Thanks again for having me. I'm happy to answer any questions.
Great, thank you so much. So I have a lot of questions, but I'm going to start with we've all talked about sort of raising awareness or raising the visibility of these issues, and how there's a lot more understanding of end-of-life care and hospice benefit now than there was 10 years ago. And I'm a big fan of Atul Gawande's Being Mortal. I think that helped a lot of people understand some of the issues at the end of life. And Kim, you and Kathy were so open in sharing your journey on Twitter and social media. I remember last summer seeing your explanation of how when people's bodies start shutting down and they don't want to eat, and how caregivers it's so hard to see somebody not wanting to eat, and our natural instinct is to say, here, eat, here's a bite, and feel helpless when you see somebody not eating. And yet you explained why that's a part of the body shutting down. And then I remember it was very moving when you showed Kathy's breathing, and to help people see what that's like. And Donna, you talked about your body shutting down. And so how do we help people understand these issues so that they can be better caregivers when they're faced with this, so that they understand this is sort of part of the process, as hard as it may be, and that, when we do something like try to force them to eat when they're not ready, we're not actually helping them. I think sharing it publicly helps, but what else can we do to help people understand that? And I would let anybody answer that who wants to.
So Shelley, can you hear me okay? I'm always
Yes.
worried I'm still muted. That's actually, that thread about stopping eating and drinking was the thread that more people were direct messaging me. Tons of people, either folks with cancer themselves or caregivers, were asking me, can you send me that information? And so it's now a pinned tweet for my Twitter, because so many people asked me about it. And people have, it's interesting. I realize, as an academic who publishes and writes, the things that I shared on Twitter have had more of an impact than anything I could write in a journal, because people actually care and it's relevant. And for me, that changed the way I think about education, quite frankly, and disseminating knowledge. I think anything that we can do as caregivers or as patients to share the realities of the experience helps make it less scary for other people. And the problem is healthcare professionals can't be sharing those patient experiences because it's really an intrusion and it's not appropriate. So it's really up to us as individuals to decide if we're comfortable sharing. And it's a tough line. It's not for everybody. I have to say, it's not something everyone's comfortable with, but I think it can have an impact. I'm still stunned. I get at least 3 or 4 messages a week from people who talk about the not eating and drinking piece as being helpful, or the breathing changes. So a lot of people are really scared about what happens when someone dies. They're so scared, and they don't know what it looks like, and they're terrified. And then they're terrified about what happens after someone dies. And that's why Kathy and I felt really strongly we wanted to share all of it. And our son wanted all of it shared, because it shouldn't be that scary for people. And, you know, again, it's not a medical emergency. If you know someone is dying, they can have a peaceful death, and it does not have to be lights and sirens and awful drama, and it's beautiful. So, you know, not to over romanticize it, but because it's messy and it's difficult. But I think anything we can do to share the experiences and the rawness of it, because so often when I see people on social media, either as a patient or as a caregiver, it's all of the I'm fighting, I'm winning, things are great. And it's like, sometimes it sucks, right? Sometimes someone wets the bed and you've got to deal with it, or someone is struggling or they're vomiting, and that's all part of the process, and it's messy, but it's honest and it's real. So.
Yeah, Kimberly, I think the thing you talked about that I want to piggyback on is what it sounds like when someone is near the end of their life, and knowing that that breathing pattern is going to start sounding different. And it doesn't mean that they're in distress. It means that it's the beginning of the end. And that's just, again, I'm like you, I don't want to over romanticize it, but it's a sacred moment in someone's life cycle. And so I don't have the answer on how we inform more people, but being knowledgeable about it ahead of time then helps the caregiver. Just, you know, it helps us chill, helps us be relaxed. So I will tell you that the death that I helped with in 2019 and the death that I helped with in 2014, I was a much more cool customer than the one in 1993 where I lost it. I mean, I did everything I had to do, but it wasn't pretty. But, you know, I've gotten better at it because I know what to expect. Yeah.
Shelley, could I jump in real quick on that point? First of all, I think it's just so powerful. We have to continue sharing our personal stories. I mean, it's really the only way to normalize the conversation, as I think we're all talking about. I'm going to just offer something that's, I think, controversial and shocking, that politicians are people too, and that they have their own experiences and their own stories. And I think what we found in our work over the years in advocacy on Capitol Hill, on a bipartisan basis, is what cuts through all the political toxicity, is these personal stories. So, and that can go both ways. To Blake's point, members of Congress who have had challenging experiences with the hospice benefit, and members of Congress who have had positive experiences with the hospice benefit. I would argue both experiences are opportunities to have a conversation about what high quality end of life care looks like. So we found that that's been successful in bringing people to the table in Washington, you know, a place that you know, it's challenging to get much of anything done. I think we've made a lot of progress on this issue because of those personal stories.
Can I add one thing? What I hoped to do in the reporting, and frankly, even I did this essay that I can share with you, an audio essay with my own mother's death in November, which you know, I'm glad to hear that you sort of think that this is the that you sort of need to be sharing your own story, since it can be intrusive to sort of take others, you know, moment of death and you know, air it for the world. But you know, I think there's a great tendency to kind of make it, oh, they were surrounded by family, and you know, make it that it was this beautiful moment. When you talk to hospice nurses who would tend to tell me it was rarely the case where it was sort of the slipping away, and more often, you know, the death groans and the, you know, or the symptoms that may be a little out of control. And so, you know, even right after my mother died, the head of the hospice agency, I was at another panel event, and she said, I heard about your mom. I hope she went peacefully. And I was like, no, she didn't. You know, but I think there's a great pressure almost to kind of whitewash it a little bit, because there's a way you could frame it that sounds beautiful. Yes, she was surrounded by us, and we even sang some hymns, but we were very confused about what she needed and what she couldn't communicate anymore. Is she in pain now? Is she, you know, does she want us to take off her air? And I think it might help others just to let them know that it may be a little chaotic and you can't get around it.
Right. I actually think that this is an area that maybe hospice could be effective. In my experience with hospice, my biggest experience, of course, I experienced it with my parents, but it was different. I actually lived it for 4 months with my husband, and I found them to be incredibly helpful during that 4-month period. However, it was the last 48 hours that I felt that's kind of when I needed them the most. And that's when I felt like it was very different from my expectations. So I expected hospice to be there, you know, at the death time. So they told me when it was time to call in the family. So that was excellent that they could predict, although they said it could be arranged. But that was excellent. And they said they would check in periodically. And they did once or twice a day, but it didn't feel to me as if it was like enough, because this was all new. And then the last, I'd say 18 hours, we were totally on our own. And I mean, we were like Googling, what does this mean? What does that mean? Like, and I would call hospice, it was the middle of the night, and they would say, oh, we'll have the triage nurse come. And there was a technical difficulty. So actually that person never reached us. And I don't know, it was just like a lost call in the series. And that was, I understand that. However, it seems to me, I was even going through the manual that hospice gave me, and they had all kinds of details about, you know, the dying, but not the end, the very end. There just was not enough information about that last period of time, which for us was maybe a little bit more than a day, where the breathing gets very labored, and you know, the body gets blotchy and cold, and all that, like where they're going, what's this mean, you know? And so you know, I'm just thinking hospice reaches so many people. So if they know that that is where we need the help the most, and if it can't be a person present, at least in more information, maybe some websites, reliable websites, or, you know, just to give the tools that are necessary, because we were kind of winging it. And you know, I mean, we were praying, we were doing all kinds of stuff, we were singing, but we kind of felt like, wow, I thought that's what hospice was all about. It was like somebody's dying at home and they're there to help, but they're not there. So anyhow, but I will say during the other months, they were extremely helpful.
Yeah.
So when hearing you talk, Donna, it makes me think a lot about what's going on with the coronavirus. And a number of healthcare professionals I know are saying they're finding telehealth actually to be a really nice adjunct to face-to-face care. And as you're talking, I'm thinking there is no reason in the world why we can't have it so that as a family is needing to check in at any time, they should be able to virtually Zoom or chat. And again, this doesn't address the needs of rural communities and communities without broadband, but for folks who do have internet access, you should be able to Zoom in with a nurse and be able to say, here's what's going on, I don't know what to do, and at least be able to connect real time with someone who can give you some guidance. It's not as good as having someone there face to face, but you do want to be able to ask someone. Kathy and I spent an inordinate amount of time obsessing about her bowels, because with ovarian cancer, you can end up with bowel obstructions. And so I was constantly trying to figure out what's the right mix of how do we make sure she never gets a bowel obstruction. And we were very fortunate, and then we had a palliative care NP who wasn't overly fixated on HIPAA rules around email. And so I could email questions and they would email back. And it was like real time, I got the answers. Everyone should have that. We should be able to have someone helping us all the time.
Shelley, can I just comment on that point?
Sure. Yeah.
All such important points. And I guess I'm reflecting on this conversation and thinking about, there is, I think, sort of a careful balance. There's a lot of requirements for the Medicare hospice benefit in terms of what programs must provide. And I am proud of the programs that we represent. They're the community-based programs that are funded largely not just by the benefit, but by foundation dollars and their communities. But there is a balance between how much from a federal policy perspective we should be legislating that experience. But there should be stringent requirements, but also it is sort of program by program. And there are, like in any industry, there are bad actors out there. But I do think that we could regulate, maybe, and our members would kill me for saying this, but I do think we could actually regulate a bit more. Like, for example, the volunteer ratio, volunteer to patient ratio is actually in law. It's in the act. I think the ratio could be lower. We could have more volunteers per patient. Maybe rather than 1 to 4, we should have 1 to 2 or 1 to 3. I think there is more that can be done in the act to ensure that individuals are getting quality care. The other point I would make is just 2 weeks ago, I guess now, as a result of the, whoops, can you hear me?
Yeah.
Good. As a result of as a response to the pandemic, the Trump administration did loosen the rules. There's a lot of rules around telehealth that were written like at a time when the internet wasn't even like a thing. And they are getting rid of a lot of the rules on a temporary basis to allow for providers to connect without a pre-existing relationship to provide that type of care via telehealth. Unfortunately, that mostly, I think all of it actually is through Medicare Part B, which is physician services, and the hospice benefit is a component of Medicare Part A. So something that we're advocating for is to get clarification from CMS, the Centers for Medicare and Medicaid Services, that hospice programs could also be reimbursed for and provide that type of telehealth as components of the response to the pandemic.
Thank you, Andrew. I think the changes that the pandemic is bringing to the use of telehealth will be long lasting. And I mean, there's still there's some policy hurdles to get through, but I think that could provide some benefits to patients in the long term. I think we just have to make sure that patients are protected and getting what they need from that. And I wanted to provide one comment that we got from one of the audience members who said, almost everything I know about the dying process I learned from Kathy on Kim's Twitter. So I think just the importance of sharing is so helpful to people to get that information. I know we talked a little bit about this, but I want to address the additional needs as time goes on, during someone on hospice. I think about my father-in-law. He was on hospice for 2 years. And he, you know, when he wasn't put on hospice prematurely. At the time he entered hospice, there was a reasonable expectation that he had 6 months or less to live. But the support he got, even though it was like once a week, but the oxygen and all of the support that he got allowed him to live better and longer. And he had a good quality of life up until, you know, the last month or so, or a few months. But his needs changed obviously over time. And he lived in a rural area and he died a few days after Christmas. So he had those last few weeks when it was, when they needed more support, it was harder to get because of the holidays. And you've all talked about how the difficult it is at the very end, and that's when you need more from hospice. And Blake mentioned too that, you know, some of these things are things that if you read the way the hospice benefit is written, people should be getting but aren't necessarily getting. And how do we ensure that patients and families are getting what they're entitled to from hospice and the additional support they may need at the end? Because I think everybody agrees that it's great and wonderful and helpful, but not enough at those last, whatever it may be. I don't know if it's days or weeks, but that's where we keep hearing from you all and from others that it's not sufficient. But according to, you know, policy, maybe that should be part of what Medicare provides. So how do we make sure that people get what they need? And I'm throwing that out there to anyone who wants to answer, but Andrew, you might want to address it from a policy perspective, but
yeah, I'm happy
anybody else.
I'm happy to kick it off. I mentioned before this notion of, you know, a lot of the Medicare hospice is highly regulated, and a lot of the type of care that the programs are required to provide is actually written in current law. And as I mentioned before, that I think we could, you know, really make that we could make changes to the benefit in law through legislation or the interpretation on the regulatory side to ensure that that type of care is provided. I think something we haven't talked much about, I think your keynote speaker did, is workforce training. There's just not enough palliative care soldiers out there, Shelley, who are on the ground doing God's work. And we can legislate, and we are, to provide more resources and establish, for example, centers of excellence across the country to train more palliative care workers and to bring. I frankly, I'm actually the son of my mom has been a hospice advocate for over 40 years, since before there was benefits. She's a poet and hospice volunteer, and so I grew up in a hospice household. And she developed a documentary where she interviewed the 4 founders of the hospice movement globally with a team, and you know, they brought that to medical schools across the country. I think every physician and health professional in this country should have a basic level of training in palliative care. So I think the workforce component, we're not doing enough to support the workforce from our perspective, and we can legislate that. We can pass legislation to provide funding and to support health professionals in getting that type of training.
Mm-hmm. Kim, do you have anything to add on how do we, you know, from a policy level, or how do we advocate for getting the care that people need that maybe they should be getting through the way the legislation or the regulations are written?
I mean, I think one thing, and it's building on what Andrew was saying, I like to think beyond the hospice Medicare benefit. So regulations should really be helping us carry out the good care we want to do, not driving the care. And so rather than think about how can we operate within the benefit or change the benefit, what would happen if we blew the whole thing up and we said, what is the care that people need? And which pieces of the benefit, if any, can be saved to make that happen, and which ones can't? More and more people are looking at the continuum of palliative care and hospice care, getting palliative care engaged earlier on in people's illness trajectory. And with that idea of a continuum, I think we're going to start seeing some more seamlessness. So if, you know, Kathy was diagnosed with cancer, the day she was diagnosed, we connected with palliative care. Before she met with an oncologist, we had an appointment with palliative care. So walking hand in hand. If we had needed hospice services, boy, wouldn't it be great if it's an extension of palliative care? And palliative care is so patient focused. The patient is choosing what they want, what they need, when. No one ever said, well, it's palliative care regulations that we have to do this, this, this. So when patients have that experience of choice, that seamlessness of choice should continue to the very end through hospice. And if that's
Right.
going to happen, hospice is going to have to change the funding mechanism, because that jarring point from, hey, it's all about what you need, and now it's all about what Medicare requires, that jarring shift, I think, is going to continue to be a problem. So I say, let's not try to work within the benefit. Let's try to change the benefit. What do we need? What do patients need? And then regulation should serve patients and families. We should not be working in service to the regulation.
Yeah.
Shelley, can I just jump in on that real quick?
Yes,
Sorry.
please.
Just couldn't agree more. For the past decade or so, there's been, frankly, a movement amongst hospice providers in palliative care, the palliative care community and others, to have Medicare test these types of models upstream, quote unquote, upstream from the benefit, but similar to the benefit. So interdisciplinary team-based care, I call it immediately pre-hospice, right? So somebody who has multiple chronic conditions, maybe somebody who has, as Kim said, point of diagnosis, gets that type of supportive care. And I'm very, very proud to say that CMS and the Centers for Medicare and Medicaid Innovation are testing a range of models now upstream from the benefit to develop the appropriate approach that hopefully will become at some point permanent part of the Medicare program. Problem is, it's not paid for right now, and that's a major issue. And so I'm really, we, NPHI, CTAC, others are just thrilled to see CMS testing these models, and we hope that they're successful, and we're going to ensure that they are.
But Andrew, I just want to add one thing. If first of all, if you can comment on, are there differences between for-profit and nonprofit hospices and how they apply these, or provide the services? And then if you're talking about, somebody having a $200 a day benefit, obviously the hospice provider has an incentive to give you less for that $200 a day, because then they, especially if they're a for-profit, then they make more. So again, how do you advocate to get what is entitled to you in the existing benefit, even as we're testing new models or thinking about how do we, make sure that the models address what patients really need?
You're giving me all the easy questions. So I think from our perspective, we don't, at NPHI, we don't necessarily see it as it's not a for-profit versus not-for-profit. It's really more, what does high quality hospice care look like? And what should, I think you're absolutely right. I think that there are, and MedPAC has talked about this now for many years. There are bad actors out there. Frankly, our programs operate at about a 1% to 3% margin. A lot of the funding that they receive, again, I mentioned earlier, comes from the community. So they're really integrated into the community. And we like to say that, and it's sort of kitschy, but we mean it. We like to say that our decisions are made, sort of at the bedside, not in the boardroom. We're not-for-profit entities, and we're part of the community. So that's not to suggest that all not-for-profits are good actors as well, obviously. But again, it comes down to how do we, and by the way, to your point, Shelley, again, they're highly regulated. So how do we ensure that they're providing the type of quality care they should be? Well, they're audited up the wazoo. In fact, they're audited probably too much. And there's a heavy amount of regulation from CMS. And that process could be improved as well. And we're doing quite a bit of work in that space in addition.
Great, thank you. So I want to turn to a different question. We've been talking about the support at the end of life, but we know that cancer patients on average are not in hospice care for very long at the end of life. It's, days and weeks, not months on average. And so how do we change the discussion? Or again, it's about education, but how do we, I think there's still resistance to perceptions of palliative care, the word palliative care and the word hospice. I remember I've told this story before, but my best friend died about 8 years ago of kidney cancer, and he was a physician, and he knew that he had lived 19 months with metastatic kidney cancer, and he knew that the treatments weren't working and that he was nearing the end. And he is the one who brought up to his oncologist and said, I think it's time for hospice. And his oncologist said, well, I've never had a patient throw in the towel after one line of therapy. And so all the work he had done to prepare his family And what he had done actually was he told me, Shelley, I think it's time to bring the article. Can you print out the article and bring it to my family? And the article he meant was Atul Gawande's piece that preceded his book, that turned into his book about letting go and the end of life for cancer patients. And so I brought that, and his family, his partner and parents had read it, and he'd really gotten them on board. And then that one comment that was a pretty offhanded comment from the oncologist that just totally derailed everything, spun them up on the idea that there might be treatment options for him. They started looking into all the treatment options. The next day, he finally had the CT scan that he had not been able to have because he couldn't keep down the liquids to have the scan, saw that the cancer was rampant, and he went home with hospice care and died a week later. So he's the one who brought it up. The oncologist didn't think it was time, and he died a week later. And I know that's an extreme example. I don't think it's usually the oncologist who's necessarily resistant, but it's patients who are resistant, oncologists who don't want to have the conversation. And then, I also want to bring up a question we had from one of our audience members who said, how do we support a friend who is out of options and actively dying, but won't stop pushing for treatment and only hurting herself? So that's a big question, but I'm throwing it out there.
So I don't know if I have the answer, but here's what I would say to that person is, how do you support that friend? Ask the friend what's important to them right now. And for some people want to pursue futile treatment that has no chance of working, and they want to do it. And it's important to them. That's important to them, and that's part of their story. And they want it to be part of their story. So even though that's not a choice I would make for myself, that's not really the point. It's what that person is choosing for themselves. Asking them what they want, and then asking what's a good day for them. How do they want to spend their days? But I think sometimes within this field, we think that the right answer is that people shouldn't pursue futile treatment. And there's certainly, when we talk about distributive justice and resources, yes, there's an argument to be made that no one should pursue futile treatment. But for some people, it's really important to them that they do. And so I think by asking someone what's important to you, what do you want to be remembered for? What do you want today to be like? A tiny percentage of those people are going to say, I want to be remembered as the person who died on chemo and never stopped. And then we have to respect that. And that's hard. That's hard. As the wife of someone who chose on day one to never have chemo, we fought the opposite fight of trying to convince the oncologist, and the oncologist had never had anyone who declined chemotherapy for ovarian cancer. And she said, even my 95-year-old's consent. So that was what we were kind of doing the opposite battle. But I think it's okay if someone wants to have futile treatment. I'm sure that's an unpopular opinion for me to offer, but people have different reasons for making their choices, and I don't think we can necessarily say one is better than the other.
I think though, Kim, I would just add though that sometimes people don't necessarily know that the treatment may be futile, and I think that's a different question. If they know that it has low likelihood of working and want to try anyway, that's different from not having all the facts about the rest of the benefits.
Well, and I think, sadly, what is typically happening is people are given this picture of a rosy picture. So Kathy's oncologist, and I'll never forget it, the first time we met with her, she said, what would you say if I told you I could give you 10 good years? And Kathy was like, that sounds great. And I said to her, yeah, but you can't, pardon my French, you can't effing say that. Why would you? There's no data. But what if I told you I could? And so it's that hope, that dangling hope that is so seductive. And so because we had looked at the literature, we knew that what she was saying was in no way a reality. There was no medicine that would give Kathy 10 good years. But if we weren't who we were, we probably would have said yes. Yes, give her 10 good years, no side effects, 10 good years. And so, yeah, if she had chosen treatment that was futile but didn't know it was futile, that's a really different situation. But there are some people who know this treatment will not cure them. It will not give them much more time, if any time, but they still want to keep doing it. And that's different, in my opinion.
Right. Anyone else want to chime in on how do we help people basically get into hospice or palliative care earlier?
I mean, from our perspective, it's all about the conversation, of course, normalizing it and ensuring it goes back to statistics that I talked about in my opening statement. The fact that, you know, we still don't have a workforce that is comfortable bringing this up to people, even though people want to have the conversation, and then honoring those wishes. I mean, to Kim's point, you know, from our members' perspective, we're agnostic on what people want. I mean, they should absolutely be given, you know, accurate and appropriate information to make informed choices. But you want everything, you want nothing. It's irrelevant. It's a question of fulfilling and ensuring that the type of care for the person, and we use the term person, not patient, because it really is a more holistic way, I think, of thinking about people. That the type of care that they receive for their life, not just for their medical care, but for their life as they're nearing the end of life, is fully responsive to their goals, values, and wishes. That's not simple, but it's the goal.
Thank you. So
I think also.
Oh yeah, go ahead, Donna.
I was just going to say, I think it's very important to educate people. And for some people that requires more visuals, more charts, looking at overall survival versus progression-free survival, you know, educating people, the patient on things like that. And I think that would really help. I think if we could reduce the TV ads that advertise for medications that prolong a person's life by a couple of months, yet it has all these incredible side effects, including other cancers. But I think honesty and educating the patient, using visual support, clarifying, using, as you said, Kimberly, you did the research. I think that's really important.
So you may notice that Blake has dropped off. He emailed to say that there's a Comcast truck on his street and he lost internet at his home. So I guess the perils of all this virtual working is sometimes we see kids in pictures or hear dogs barking, and then I guess sometimes you lose internet. I did see somebody who said maybe we should all just stop apologizing for any of the background noise that happens as we're all working at home, because we're all, you know, living our lives and as we try to do this. I know I'm in the office today because I have 3 kids at home, and I knew that I could not do this and guarantee no interruptions if I was at home. So I'm here today. I would like to ask a question about inpatient hospice. I know we've been talking a lot about dying at home, but inpatient hospice can provide obviously a respite sometimes for caregivers, even if it's a temporary respite, or, you know, help for people who really can't care for the person at home or doesn't want to. What are the limitations on inpatient hospice, and how do we make that more available to people if they want it?
I'm happy to start off. Sure. And I'm just a lowly policy guy, so I wouldn't speak for the programs. And you know, if I was we could certainly follow up with one of our CEOs. But you know, there's 3, really 4, but 3 levels of hospice care that are available, and one of them, which is used, which actually is being used more, to your point, is general inpatient, and it's a much higher, much more acute level of care. But it's a specialized type of care. You're in a home or a unit that doesn't look anything like a hospital, but has all of the support that a hospital could provide. But it's when you're very seriously ill and you're terminal, and it's a higher level of care. It's reimbursed at a higher level. I think it's around $800-something per day, and a certain percentage of individuals have access to that type of care. But routine home care, which is really the vast majority of individuals are on routine home care for hospice and not general inpatient care. But happy to, it's become a big issue because it's being used more. Because it's reimbursed at a higher level, and I would suspect that the Congress and that CMS would take a closer look, frankly, at how that care is being reimbursed and being used, given that we're seeing sort of explosive growth in that space.
Thanks, Andrew. There was also a question about, is there any legislative movement for insurance coverage for private duty nursing care for in-home hospice care? I mean, and we've talked mostly about Medicare, but can you talk a little bit about private insurance coverage?
Yeah, there isn't legislation to my knowledge. If there's somebody that's listening from, one of the associations that does, American Nurses or others, please, forgive me. But private duty nursing is growing. A lot of our programs, again, going back to one of the points that were made earlier in the conversation, they don't see themselves as just hospice providers, but they're also doing private duty and have contracts with private health plans to provide that type of care. They're also doing, a lot of them are doing home-based primary care, which is being tested now under the past 6 years under the Independence at Home demonstration program. A lot of them are contracting with private health plans to do home-based palliative and primary care. And so I think what we're seeing is the hospices being, staying true to their the original intent of sort of the benefit of what hospice is all about. It's really the original sort of person-centered care model, but getting into private duty and getting into home-based palliative care and getting into home-based primary care and other lines of business with private health insurance companies. And you don't need to legislate to do that. That would be a contract that a private health plan could in a hospice program could do on their own. The other thing is, I mentioned Medicare Advantage in my opening remarks. It's just under, well, about 34% of the Medicare program is private health insurance. And they've got the private plans now through Medicare have an extraordinary amount of flexibility to pay for and provide benefits for home-based palliative care. So I think we're seeing a lot of opportunity. I think Kim made this point to have hospices be siloed and to really get into other lines of business, whether it be private duty, home-based primary care, or otherwise.
Great, thank you. We're almost out of time, but I want to end with one question about, because I know we talked a little bit about COVID-19, and I did hear today that a lot of medical professionals are considering, having a blanket DNR for patients who are in the hospital with COVID-19, regardless of the family's wishes. And I'm wondering if anybody wants to comment on that. Obviously that's a difficult, it's a totally unprecedented situation we're in, but I didn't know if anybody had any thoughts or comments on that.
Yeah, I'm amazed by that. I'm amazed by that because when my father was near the end of his life and he did not have an advance directive, and I tried to get his doctor in the rehabilitation facility to walk him through preparing a DNR. The doctor was so resistant. He's like, oh, well, this, it might not happen this way. I am stunned that the medical community would go from one extreme to the other. I'm just stunned by it. That's stunned. That's my word, because that is not my personal experience. It wasn't my personal experience with my mother when I was trying to get a doctor to help walk her through in the medical parts of the advance directive, healthcare power of attorney, and the doctor just kept poo-pooing, oh no, you don't, oh no, so both of my parents died without advance directives. In both cases, I had to be the one to step in because they were so convinced by the medical community that, oh, I'm stunned. Okay, I'll shut up. I'm just stunned.
Lisa, my understanding about why they're making that move is not because of a recognition that the people who have COVID-19 might not make it, but more that any resuscitation attempt, it uses lots of equipment. So a lot of people have to be involved in a resuscitation attempt. There are droplets, there is exposure risk, there are people wearing masks. And so from what I was reading, that was driving some of this discussion, is not so much that they think someone can't be saved, but recognizing someone may not be able to be saved and multiple people may be exposed. I was shocked to see it as well. Part of me wonders if 5 years from now, we may see a default just in our country become do not resuscitate becomes the default for anything, unless someone has said they want
Right.
to be resuscitated.
Then you have to opt in the other way. Yeah.
As an opt-in, because there's certainly some circumstances where resuscitation is attempted and isn't successful. And so I don't know what's going to happen down the line long term with this. I think short term, we're going to see some grieving families. I think there's going to be a huge need for bereavement within hospital settings. I think local community hospices will probably end up being the ones that will be turned to step in and provide that bereavement support in communities. So I hope that there will be financial support for community-based hospices who end up stepping in and meeting that need, because that is where the communities, I think, will turn.
You're here.
Well, and especially because it sounds like, people are not able to be with their loved ones at the end because of this, which I think just adds another trauma on top of losing them, but that they can't be there with them.
And Shelley, with the knowledge that a family member cannot be with, in particular, an elderly person, we learned from Italy that in areas in Italy, they began to tell families to keep their elderly family members, people over the age of 80, keep them home. And I've been thinking a lot about that in my own personal situation with multiple risk factors for COVID and pneumonia. And a couple of thoughts. One is that, what kind of DNR am I taking equipment away that could be used for a younger person, in which case I would say, of course, I've lived a full life. But the other idea is if I get COVID and other people like me, do we call and try to get into the hospital, or do we call our primary care doctor and say, I'm going to be staying home. Can you send me not only some medication for pneumonia, but also maybe some morphine, and then go from there? And is that going to be something that we need to talk about for the people who decide, for the elderly who decide to stay at home? And I know personally I would be comfortable with that. I think that would make more sense than dying in a hospital bed alone. Of course, there are a lot of unknowns, you don't know. So it's always balancing probabilities. But it would be nice if you decide to stay home to be able to get access, ready access, I don't know, through hospice, whatever, to whatever medications you need for comfort.
Well, it makes me think immediately of, for people who have a pre-existing condition of some kind that makes them vulnerable, whether it is cancer or an autoimmune disorder, and they get COVID-19, would their physician say that they may have a life expectancy of 6 months or less? I see Andrew going, no, don't send them all to hospice. But if someone is sick already, right? So let's say someone's sick already. Let's say someone has cancer. They have advanced cancer, they're on chemo, and if they get COVID, could they access the hospice benefit? I see Andrew is like visibly cringing. Like,
no, I'm trying to ignore my fiance who's making faces at me and wondering if I'm still on this call.
Oh, I'm sorry. But it is an interesting thing. Would funding for hospice, right now hospices, if we had more robust funding to help hospices step up and provide in-home care for patients with COVID, would those patients be eligible for hospice, right? And could we prevent further infections of healthcare providers in hospital-based settings if we can figure out a way to provide care at home? And maybe that is a combination of telehealth. Maybe it is not in-home, a nurse going in the house. Maybe it's delivering meds, bringing DME, providing oxygen. I know there is some literature now looking at CPAP use when ventilators are short. So could hospice be doing this?
Yeah, the answer is yes. I know we're over time, Shelley, but I would just say that these are extraordinary times we're living in. I've seen more changes in terms of public policy in 2 weeks than I've seen in my entire career. Not since the Affordable Care Act have we seen major decisions in healthcare being made, and at this speed. It's pretty extraordinary. Hospice is going to be, is and will continue to be a big part of that. And I think to Kim's point, you know, we are frankly, our programs are just triaging and trying to figure out how best to support and manage this population. I mean, they're just trying to get protective equipment at this point, which they can't get. They can't get the masks. They can't get the, and you know, we were on the phone with the CEO of 3M just a couple of days ago, begging for equipment. So we're at that point in the pandemic, not at the how do we, you know, serve more people at home. But I think if you look in your crystal ball, I think that's where we're going. And no doubt our members will be right in the center of that.
Great. Well, thank you all so much. We are a little bit over time, but it was such a great discussion that I just wanted to be able to conclude. And I feel like we have to bring everything, you know, we have to recognize the reality that we're in right now and talk about how COVID-19 may affect all of these issues. So I want to thank each of you for joining us. It was a wonderful discussion. I appreciate you sharing your experiences and knowledge, and thanks to Blake as well. Sorry that he had his technical difficulties. So we are going to take a break for about 7 minutes. We'll start up again at noon with our next panel discussion. Thank you all.
Thank you, Shelley.
Thank you
Thanks
so much.
everybody.
Thanks. Bye. Bye, Donna. Bye, Kimberly.
Bye. Bye.
Bye.